Hello guys, this is Vikrant and Sengar, pursuing MBBS from GRMC Gwalior, now presenting a beautiful lecture on the great topic that is the IBD Part 2 with the 6 subject integration. As it's better to strike 10 times at a single point of the tree rather than 10 different points for one time, just like that. So guys, I have posted my notes on my Instagram account, that is the Integrated Medicos. Do check it out. But now we will go for the part 2 of IBD here. Now we will go for the diagnosis here, right? And the first thing is the Montreal's classification for the clinical assessment of CD, and then the TRUELOVE WITT's severity grading for the clinical assessment of UC here, and then the radiodiagnosis and the name signs as well, and subsequently the comparative endoscopic study as well, and then the comparative histopathology and the lab investigations as well here, right? So now we will go for the clinical assessment of CD with the help of Montreal's classification here, right? And this classification is having three components. Number one is the age of presentation of the patient, and then the behavior of lesions, and subsequently the locations of the lesions here, right? And when the age of the patient is less than equal to 16 years, that is categorized as A1, and if it is 17 to 40, that is A2, and if it is more than 40, that is A3 here, right? This is what the age component. Second thing is the behavior of lesions, and when the patient is not having any stricture or not having any penetration, that is categorized as B1, and if the patient is having strictures, name it as B2, and if it is having the penetration, name it as B3, right? And when the patient is having the perineal involvement, that is the fistula or the fissures at the perineum, that is categorized as P, and subsequently the location of the lesions, and when the lesion is present at ileum, name it as L1, and for colonic lesions, L2 is there. For ileocolic lesions, the L3 is there, and L4 means the isolated upper GI involvement, right? So this is what the picture, and this is what the Montreal's classification. Now just take a clinical case to understand Montreal's classification better, right? So a 25-year-old male, 25-year-old male, right, is presented with the colicky pain is there. So colicky pain is there at the right iliac fossa. Okay, so now we will classify according to the Montreal's classification here. So number one thing is the age of the patient, that is 25 years. So it is having A2 in category, right? And then the patient is having colicky pain, that is because of the strictures. So that is having strictures. So B2, A2, and then B2, right? And subsequently the pain is at right iliac fossa, right? So ileum is present at right iliac fossa, so ileal involvement is there, so L1. So Montreal's classification for the diagnosed case of CD, that is A2, B2, L1, that is according to Montreal's classification. And now we will go for the TRUELOVE WITT's severity grading for the clinical assessment of UC, and the grades are mild, moderate, and severe here, and the parameters including the first is the frequency of defecation here, right? And the frequency of defecation, and if it is less than equal to 4, name it as mild UC, and if it is more than equal to 6, name it as severe UC. And second category is the bloody stools here, right? So it may or may not be present in the case of mild UC, but the massive flow of blood is there in the severe category, right, of UC here. And third thing is the fever, which is absent, but that is more than 37.5 degrees Celsius in the case of severe UC here, and subsequently tachycardia absent, that is more than 90, and subsequently the blood findings, right, and anemia and ESR, right, and both are normal. The hemoglobin level is normal in the case of mild UC, and ESR is also normal, right, and anemia is there, and the severe anemia is there, and the hemoglobin level is less than 10, that is a mild anemia, and if it is less than 6, that is severe category of anemia here, and ESR is more than 30 mm/hour, that is basically higher level of ESR, which is there in the case of severe UC here. This is it with respect to the clinical assessment, and now we will go for the lab investigations, and that is done with the help of antibody screening, right? And the CROHN's disease is more commonly found to be associated with the ASCA, that is anti-Saccharomyces cerevisiae antibody, and second is the UC, and that is more commonly found to be associated with the P-ANCA, that is perinuclear anti-neutrophilic cytoplasmic antibody, right? So these are basic antibodies, and subsequently the anti-flagellin antibody and anti-outer membrane protein citrullinated antibody is present in the Crohn's disease here, right? And now the non-specific blood findings, and the ESR and CRP both are elevated, and then the hemoglobin level is lesser in the both conditions, and the TLC, the total leukocyte count, is increasing in both the conditions, that is CD and UC, and subsequently the serum albumin, and that is lesser in the case of UC, since massive flow of blood is there in the UC. That's why the serum albumin is decreased severely in the case of the severe case of UC here. And now we will discuss the fecal procalcitonin and the fecal lactoferrin. And since it is inflammatory condition, I mean the CD and UC both are the inflammatory condition, that's why these markers are elevated in the case of IBD, and these markers are normal in the case of irritable bowel syndrome, since the gut inflammation is not present in the irritable bowel syndrome. And now we will go for the comparative study among three things. Number one is the pathogenesis taken from pathology, and the endoscopic findings, I mean the upper GI and lower GI endoscopic findings taken from medicine, and third thing is the radiological findings taken from the radiology. So guys, this is what the essence of integrated medical science, that we can discuss multiple things at a single point of time. And now we will discuss the same thing for the CD here, right? And as we have discussed the pathogenesis of CD, number one presentation is of the aphthous ulcers, right? So aphthous ulcers are there. Okay, these are the ulcers, and surrounding to these, this is the edema there, and same thing is present at the endoscopy, and these are the aphthous ulcers, and surrounding to these ulcers we have the edema, right? So edema is there. That is what the endoscopic findings are there, right? So this is what the endoscopic findings, and now we will go for the radiological findings here, and that is just looking like this. These are the ulcers, right? And these are just surrounded by the edema here, right? So in the radiology, these are showing the target sign. So that is the target sign or the bull's eye sign. That is the first thing of CD here. And now second presentation is the serpentine ulcers. This is the aphthous ulcers, and now we will go for the serpentine ulcers there, right? So these are the serpentine ulcers, and that is having the erythematous mucosa in between. Okay, and this line is of serpentine ulcers, and that is having erythematous mucosa in between, and these are looking like that, right? These were the ulcers which are coalesced and resulting into the formation of the serpentine ulcers, and this is having the erythematous mucosa in between, right? And these were the cobblestone appearance. So this is what the cobblestone appearance upon the endoscopy. And now we will go for the same thing of radiology here. So this is what the gut wall, this is the gut wall, and these cobblestones looking like that, right? These were looking like that. So that is the lumen which is filled with the contrast, right, which is radio opaque here. So the lumen is filled up with the contrast material, and this one is the projections coming from the gut wall in the luminal surface, and these are the cobble stone appearance. Okay, so this is what the second presentation of that, and third presentation is the fissure formation here. Now we will go for the third presentation, which is the fissure formation, the transmural fissures and the ulcers which are reached up to the muscularis propria, right? So these were the gut wall, and these were the fissures formation, and this is mucosa and submucosa, and this is a layer of muscularis propria, and that is our fissure. Okay, that is third presentation, right? And subsequently the endoscopic findings, in which it is looking like a hole, an ulcer, a fissure, a deep ulcer. So in the case of endoscopy, we find there is the holes or the fissures are present when we approach from the luminal side. Okay, so this is what the fissure, right? And that is the mouth of fissure, and that is the fissure actually, right? And surrounded by the inflammation and erythema, right? And when we switch to the radiological findings, we find this is our lumen, and that is our gut wall, right? And this is our fissure, that is our fissure formation here. Okay, so that is just looking like a rose thorn appearance, and that is giving a rose thorn appearance, and the lumen is filled up with the radio opaque dye. So this is the appearance, that is the rose thorn appearance, right? So this is what the rose thorn appearance, and this is the lumen filled up with the radio opaque dye. And since this dye is also filling in the fissures, and that is giving like the thorns of rose stem, that is the rose thorn appearance. So this is what the basic pathogenesis of CD. And now we will go for the next presentation, that is the transmural ulcerations, and subsequently the fat halo sign and the COM sign as well. So this is what the bowel loop, and that is having the transmural inflammation here, and subsequently the mesentery, and the mesentery is having the vasa recta, and these are dilated because of the inflammation. So dilated vasa recta, right? And this is what is looking like the strings of COM, that is showing the COM sign. And we can't see the mesentery in the case of endoscopy, since we are observing the lumen. Okay, we are not observing the serosa here, so endoscopic findings are not present with respect to the COM sign and the creeping fat sign. But now we will go for the radiological findings here, right? So this is what is looking like these strings of COM here, and that is the bowel loop here. So that is looking like strings of COM. So COM sign is there, and subsequently the fat is there, and that is the fat that is adhered at the mesenteric border, right? And that is also called as the creeping fat sign here. So creeping fat sign is there, and this is looking like that in the case of radiology. Okay, creeping fat sign is there. Okay, so that is our bowel loop, and at the mesenteric border the adherence of fat. So this is what the COM sign plus creeping fat sign here. And now we will see the string sign of KANTOR here. Okay, so this is what our bowel loop here, and this is having the granuloma, right? So these are what the granuloma, and these are causing the chronic inflammation and resulting into the stricture formation, and the fibrosis and stricture is there. So that is looking like stenosed and narrowed bowel here, bowel loop here. And when we go for the endoscopy, this lumen is becoming narrowed because of the stricture formation, right? This is what the endoscopy, and now we will go for the radiology here. And now we will go for the string sign of KANTOR here. So that is our normal ileum here, but the terminal portion of ileum is narrowed here, right? The terminal portion is narrowed here, and that is our cecum here. Okay, so terminal ileum is become narrowed, and that is called as the string sign of KANTOR here, and this is our contrast that is filling in the lumen. So this portion is the terminal ileum that is narrowed and stenosed, and that is having this stricture inbuilt, and that is called as the string sign of KANTOR here. Okay, so these are what the radiological findings and the endoscopic findings and the pathology with respect to the pathogenesis of Crohn's disease. And now we will go for the same thing of UC here. So now we will discuss the pathology in correspondence with the endoscopy in the correspondence with the radiology, right, with respect to UC, right? So first presentation is the superficial ulcers here, right? So that is okay, our colon, that is more commonly seen in the case of rectum, and subsequently that is involving sigmoid colon and reaching up to the entire colon as well, right? So this is what our rectum or sigmoid colon basically, and that is having the superficial ulcers as a first presentation of that. So having superficial ulcers, and that is looking like that. Superficial ulcers are there. Okay, that is superficial ulcers. Okay, and these are just appearing as the fine mucosal granularity. So this is what the ascending, transverse, descending colon, and sigmoid, and the rectum as well. Okay, so that is involving the rectum and the descending colon portion first, right? So this portion is having the fine mucosal granularity. And second presentation is as these fine ulcers are becoming more deeper and reaching up to the submucosa in the form of broad base ulcers. So there are the broad base ulcers are there. Okay, so these are the broad base ulcers, right? And when we're just going for the endoscopy, basically the proctoscopy or sigmoidoscopy, we will find that there are the ulcerations here. Okay, there will be the erythema ulcers and the broad base ulcers as well. Okay, that is the mouth of ulcer, and that is the whole thickness of ulcer here, right? This is what the endoscopy or colonoscopy or proctoscopy basically, right? And third thing is the radiology, and we will go for the barium enema here. And once which is going for barium enema, this barium is filling in the lumen, and that is also filling into this broad base ulcers as well. So these are appearing as the collar button here, and that is our descending colon, that is transverse colon, and that is the lumen, right? And which is filled with the radiopaque dye, that is the barium enema, right? And that is our rectum here, right? And that is descending colon, and showing this collar button ulcers here. Okay, and that is our gut wall. Now as disease progresses, and this is our broad base ulcers, right? And as disease progresses, the chronic inflammation is going on, and the growth factors will be released and resulting into the proliferation of mucosa, right? That is the proliferation of mucosa resulting into the pseudopolyp formation, right? That is our pseudopolyp formation. So as in the case of colonoscopy, we will find the numerous pseudopolyps here, right? Pseudopolyps will be there upon the colonoscopy. This is what our colonoscopic findings here. So this is what the barium enema filled in the lumen, and that is descending colon here, and that is having these pseudopolyps here. These are the pseudopolyps which are protruding towards the lumen here, and that is the ball. So the appearance called as the islands of normal mucosa. These are the pseudopolyps which are normal mucosa, and the islands of pseudopolyps in the sea of atrophic mucosa. Right. So that is the island of normal mucosa present in the sea of atrophic mucosa. This mucosa is atrophic mucosa. Okay. So these are the islands present in sea of atrophic mucosa. Next appearance is the lead pipe appearance, right? And as disease progresses, there is loss of hostrations leading to the lead pipe appearance of colon here. Okay, so that is having the lead pipe appearance. Okay, normally the hostrations are present here and which are absent in the case of lead pipe appearance here. So now we will go for the same appearance over the radiology. This is descending colon here, right? That is transverse colon, and this is the ascending colon. Okay, as disease progresses primarily over the descending colon, that's why descending and transverse colons are involved first here. Okay, so lead pipe appearance is present at the descending colon, and that is still not present at the ascending colon here, right? So lead pipe appearance is there, and which is filled up with the barium enema, the radiopaque contrast here. So now we will discuss the toxic megacolon is there, right? So the diameter is more than 6 centimeter. That is transverse colon, that is descending colon here, right? And this is because of the destruction of orbital plexus, right? Since that is maintaining the tone of the muscle, the smooth muscles, and once it is lost, there is abnormal dilatation of the wall that is causing toxic megacolon is there, right? So abnormal dilatation of the wall. In the radiology, we will find there is massive dilatation of the wall, right? So this is what the transverse colon here, that is descending colon, and that is the barium enema filling the whole of the colon there, right? And the diameter of transverse colon is more than 6 centimeter, which is diagnostic for the toxic megacolon is there. So this is what the radiological findings, endoscopic findings in correspondence with the pathology. So now we will go for quick radiology here. Number one thing is the string sign of Kantor, that is string sign of Kantor here, the narrowed terminal ileum here, and subsequently the cobblestone appearance here. Okay, there is the cobblestone appearance here, and the aphthous ulcers. These are the aphthous ulcers there. This is what the findings of CD, and now we will go for the findings of UC. Okay, so there is the lead pipe appearance there, right? That is showing the lead pipe appearance there, right? Lead pipe is there, and this is showing the fine mucosal granularity, the earliest presentation of UC here. And now we will discuss the CD findings, that is the com sign here, right? Let me just magnify that, right? So this is our loop of the vowel, right? And these are the strings of com, and that is our mesentery, right? So this is basically this CT finding, the CECT finding, the contrast enhanced CT scan, right? This is our com sign, right? And there is the fat adherence here, right? And the fat here as well, and this is called as the creeping fat sign, right? And that is not present at anti-mesenteric border. Okay, so this is it with respect to, and now we will discuss toxic megacolon here, right? So this is our transverse colon. Diameter is more than 6 centimeter here, and that is showing the lead pipe colon. Okay, the characterless colon, the lead pipe colon. Okay, and this is our cecum, diameter more than 12 centimeter. That is our gross presentation or endoscopic findings, and we have discussed it previously, but now we will go for the enumeration as well. Okay, so first thing is the CD findings, and we will go for the upper GI endoscopy and the lower, that is the colonoscopy, and the site of CD, that is the ileum, right? And subsequently the colon, and third one is the ileocolon findings, right? And then the APHTHOUS ulcers we have discussed, APHTHOUS ulcers, the serpentine ulcers we have discussed, and the cobblestone appearance and the fissures and fistula, we have discussed all these things. And nature is the skip lesions which are transmural here. And now we will go for the same thing, the endoscopic findings such as the colonoscopy and proctoscopy, since it is involving lower GI more commonly, and then the site, more common site is rectum, and subsequently the descending colon and transverse colon as well, right? And mucosal lesions, we have discussed the fine mucosal granularity first, and second is the pseudopolyps here, and third thing is the broad base ulcers, and the fourth thing is the toxic megacolon. We have discussed all these things right now. Next thing is the superficial ulcers which are continuous in nature. Superficial ulcers which are continuous in nature. Okay, so this is what? So now we will discuss the Mayo score, that is basically the endoscopic criteria for the assessment of UC. So we're just having 3 grades: mild, moderate, severe here, right? And score is 1, 2, 3 respectively. And now in the case of mild and moderate, we're just having erythema in the mild, but the marked erythema at this moderate variety. And then vascularity is decreased, but there is lack of vascularity. Okay, and the friability, which is mild, and that is severe in the case of the moderate category. And now the severe category is having the spontaneous bleeding without any mechanical trauma. There is spontaneous and massive bleeding, and subsequently the ulcerations which are superficial and continuous and having the broad base ulcers. So this is it with respect to the endoscopic findings, and now we will go for the histopathology, right? So that is, first is the CD, right? And this is the ulcer. Initially that was ulcer, but now that is converted into the fissure since it is transmural, right? That is transmural fissure, and subsequently this whole structure is of crypt, and there is inflammation of crypt known as cryptitis, and then this whole structure that is of granuloma. So granuloma is formed here, okay, and made up of the activated macrophages. These are the epithelioid cells, and this is the normal structure, that is muscularis propria or muscularis externa, having CML and LML, right? And this is our crypt, and there is crypt distortion, right? That is more commonly seen in the case of ulcerative colitis, but that is present here as well, right? And this is the lymphoid aggregates or lymphoid follicles here, okay, and these are the lymphocytic infiltration of muscularis externa, right? There is transmural inflammation here, and subsequently the same thing of UC is there is broad base ulcers. This is the broad base ulcers, and this is our normal crypt here, right? Normal crypt is there, and this is also crypt, this is also crypt here, okay, and this is crypt abscess. There is crypt abscess is there, right? And then there is basal plasmacytosis. These are plasma cells which are present at the lower border of submucosa, okay, just above to the muscularis externa. So guys, this is our crypt abscess, this is crypt distortion here. This area is of crypt distortion here, and that is our crypt abscess, and there is cryptitis, crypt abscess, and crypt distortion is there, right? So this is it with respect to the histopathology and diagnosis of UC and CD. And thank you for watching, and I hope that you like this video. Thank you very much. So guys, if you're just having an doubt inquiry, you can go for the comment section below, hit the like button for the sake of the integration, and don't forget to subscribe. Pressing bell icon will give me some vibe. So guys, we will meet at the another section of disease, that is IBD part 3. So till then, keep integrating. Thank you.